Okay, so for the next 20-25 minutes, we will talk about parenteral nutrition. So we'll go with the basics and then we'll see how to monitor, how to prepare, and what to expect, any complications from this. So from the first talk, you must have learned that we have some, newborn babies in the NICU, particularly preterms, have nutritional deficiencies in the first, how many weeks? 2 weeks of life. Why? Why do you think? So that happens because we are not ready we are not on full enteral feeding. So sometimes they take up to 2 weeks to go to full enteral feed. So when they are born, the abrupt cutoff of nutrition from placenta and the time that they reach enteral feeding is a long gap. Sometimes 2 weeks, sometimes up to 4 weeks if they are very sick, very preterm. So that is the need for parenteral nutrition. So this started somewhere in 1980s. Then it acted as a bridge between placental nutrition and the neonatal nutrition, right? So for right now, the practice in most NICUs which do parenteral nutrition is to start right at birth so that this deficiency is avoided. So 1968 was the first time somebody tried parenteral nutrition in newborns, right? Till then, if the baby was not able to take feeding well, the baby would die because they had no energy source. So energy and protein source. So that was the first time somebody tried and they successfully maintained them on parenteral nutrition. And then 1980s, the TPN got better. They started using crystalline amino acid solutions which are better tolerated. And then now because we use PICC lines, we can give long duration of TPN. So but our challenge still is we still don't know what is the optimal regimen of a parenteral nutrition. So as we said, why do we need parenteral nutrition? There are no reserves. So very preterm babies, extreme preterm babies have minimal fat. They don't have glycogen stores. They have very high metabolic demand. Why? Because they have breathing issues. Second, growth. Brain grows very fast at that time. And then temperature regulation. And if on top of it, if they have other issues like infection, surgical issues, they need more demand. The gut is still immature. Extreme preterms who are born borderline, they have very immature gut and they will not take full enteral feed soon. So without parenteral nutrition, what happens? They can go into hypoglycemia. They'll break down their own body stores. So they'll lose weight. So by the time they regain weight, it becomes a very long journey. So that can lead to growth failure. So what are the components of parenteral nutrition? Anybody wants to guess? What do we give as part of TPN? Doctor?
So, lipid.
Lipid, yes, okay.
Amino acids.
Amino acid, okay.
Protein.
Sorry? Carbohydrate. So those are the macronutrients. So protein, carbs, and lipid. What about the micro? What all do we use them? In TPN, microelements, micronutrition, electrolytes, any trace elements, right? Calcium, phosphorus, minerals. Okay. So first we look at amino acids. So what happens is in the uterus, the baby gets around 3 to 4 gram per kg per day of amino acids. But the actual intake, the accretion is not that much. But probably these amino acids are used even for energy source in when the baby is as a fetus. Postnatally, they have found that for growing, protein requirement is about 2 gram per kg per day. But you lose about 1 to 1.5 gram in the urine. So you totally need how much for growth? 2 plus 1, at least 3.5 to sometimes up to 3 to 4 gram per kg per day of protein requirement. How much glucose should we give to these babies? So primary source of glucose, energy source for the brain is glucose, right? And then they have no glycogen stores, very small preterms. So if you don't give enough, they're going to have hypoglycemia. So at least from the day one, you should give energy that matches the basal metabolic need. It's called resting energy expenditure, and that should be around 40 to 60 calories per kg per day. And if you know the glucose infusion rate, it should be at least around 4 to 6 GAR. Okay, and then go up as required. So what is the risk when you give this dextrose? Most hyperglycemia is less common compared to hyperglycemia, but hyperglycemia, unless it is going into triple digits like more than 200, you don't usually treat with insulin. You try to reduce your JARs and C. Now some units have, use insulin as a routine for these small babies, very, very small, but then the studies don't support any benefit from using insulin. Actually, it can cause some harm itself. So we don't do insulin regularly, but if you have trouble with hyperglycemia, you can use insulin. Lipids. So intralipid is the most energy dense macronutrient, right? So it gets up to 9 to 10 calories per gram. So it is also critical for having essential fatty acids, which are So there are some essential fatty acids called linoleic acid, alpha linoleic acid. These are omega acids. So these deficiency can happen at birth. So definitely we need to give them through intralipid solutions. And there are some other lipids which are conditionally deficient, essential. That means you must have heard of DHA, ARA, formulas containing DHA, right? These ones are also conditionally essential. That means the body is not able to produce as many of these fatty acids as the baby requires. So these also need to be given through parenteral nutrition. So you have to once you give lipids, you have to monitor for triglycerides. So how much is the triglyceride level in the blood? If it's going beyond 170 to 240, you might have to reduce your lipid rate. So there are different types of lipids that are available. The older lipid was only made from soybean. So the latest one is called SMOF, which is a mixture of different types of lipids. One is soy, fish, and olive oil. So this is called SMOF. This SMOF lipid is supposed to be better than the interlipid derived from soy in that it reduces inflammation, can reduce cholestasis and liver injury in the long term. Okay. So how much do you start? So on day one, if you're starting parenteral nutrition, you should start amino acid at 1 to 2 grams. 2 gram is good. 2 gram per kg is achievable easily. Lipid, again start with 1. Carbohydrate about 6. So total energy should be 40 to 60. The target dose, amino acid should reach 3 to 3.5. Intralipid also should reach about 3 by by increasing every day about a gram or so. Coming to what electrolytes and minerals use. Sodium. What is the requirement? The dose range is about 2 to 4, but sometimes you need up to 6 milliequivalents per kg per day also if the baby sodium is less. And sodium would be added like using 3% saline. So 1 ml of 3% saline has how much sodium? 0.5. Very good. Potassium, the requirement is about 1 to 2. So if you are using potassium chloride, 1 ml is 2 milliequivalents. But if you want to avoid using chloride because high chloride can cause acidosis, if you want to avoid chloride, you can use potassium acetate. It is also same, 1 ml is 2 milliequivalents. Magnesium is the other one that you can add. Coming to calcium and phosphorus. The challenge for calcium and phosphorus is they can get precipitated. So how to prevent the precipitation? You should keep the ratio of calcium and phosphate at least is 1:1. Maximum you can go up to 1.7 to 1. Okay, don't cross that. If you're crossing that, then both of them will have a reaction and then they precipitate and it's very dangerous for the baby. So how do you give calcium? Calcium gluconate, right? 10% calcium gluconate. So 1 ml of calcium gluconate is how many millimoles? 0.2 millimoles. Very good. Phosphorus, how do you give? Sorry, ma? So either sodium phosphate or potassium phosphate, and slightly different millimole difference in that. Sodium phosphate has 3 millimoles of sodium and 4 millimoles of phosphorus. Whereas for potassium phosphate it is 3 and 4.5. Okay, so we have to calculate for each ml and see, and both of them, calcium you can start at 1 millimole per kg per day, it can increase up to 2. Phosphate again you start with 1 and daily you increase, go up to 2 to 3.5. Just make sure the ratio is correct, and you have to add calcium first and then phosphorus. And anyway, amino acids has a acidic pH, so that helps with preventing precipitation. Okay. Okay, I think we have spoken about that. There is one more organic form of phosphate called sodium glycerophosphate, which is better soluble than this inorganic sodium phosphate and potassium phosphate. Okay, if that's available, it's better to use that. How do you monitor these things? Electrolytes every day, first few days. Sometimes in the first 48 hours you might have to repeat frequently, even 8 to 12 hourly. Calcium, phosphorus, magnesium, monitor 3 to 4 times initially first few days, and then weekly or every 2 weeks. Okay. So what amino acid solution do you use in your units? Do you use aminoven? 10% amino acids. Okay, so 100 ml has 10 grams. Interlipid 20%. Very good. I think that is enough with that. Main thing is about preparation and keeping it aseptic, because most problems with parenteral nutrition in India comes from infection. So it has to be extremely sterile. You should have a laminar flow. You all know, have seen a laminar flow, right? It might be there in your microbiology units also. Make sure the preparation is under the laminar flow with UV radiation and everything. So otherwise it becomes aseptic. You will end up giving infection to babies, and the whole point of giving parenteral nutrition is lost. So how many of you have heard about aseptic non-touch technique? ANTT? No? So that is a method of using scrubbing, and then you're not touching anything that we are directly going into the baby unless it is sterilized properly. We'll show you a video later as to how to do this ANTT. Okay. So one thing is aseptic preparation. The recommendation is not to add these vitamins, minerals, electrolytes in the wards. This recommendation comes from Western societies where the TPN is prepared in the pharmacy and sent to the unit. But here, because we do it in our own NICUs, that doesn't hold good for us, but we must make sure that we are doing it sterile. Photoprotection, that means photo-oxidation should be prevented. All this can lead to superoxide radicals in your TPN if you don't cover it. So cover your TPN preparation properly. Again, use an inline filters. So how many of you use a filter for TPN? So you use it. It is better to, it will take off the precipitation if it happens, at least 1.2 micron size. If you have even smaller, for aqueous solutions, if you don't have lipid, you can use even up to 0.2 micron size. That will even filter the bacteria. Okay. Some trace elements that we add to TPN, generally we don't follow this much in India. I'm not sure if anybody else uses trace elements in TPN. Yeah. So, yeah. That iron we don't usually do. Zinc and selenium are essential for immune function and skin. So those need to be added. Vitamins, again, fat soluble vitamins are added to the lipid solutions. Carnitine is also sometimes added, but routinely not recommended. So monitoring for biochemical, again, I think we have spoken about it, but daily monitoring of electrolytes, glucose, even 6 hourly, 6 to 8 hourly we need to see. Insulin has to be used if you are having persistent hyperglycemia despite reducing GARs. triglycerides monitor. Once you reach about 2 to 3 gram per kg of intralipid, you try to check your triglycerides. If they are more than 170 to 240, you have to come down on intralipid. So what are the treatment related problems? Yeah.
We don't actually.
My training in Canada, we start with one and then check. Right now, I think the idea is not to see
Only total parenteral nutrition and for a prolonged
period. Yeah, yeah,
triglycerides, magnesium.
Yeah.
So we have a set of protocol. The protein we don't want. Previously, when I used to be in UK, we used to give gap of 4 ml, then take it.
check. Yeah, yeah.
Now it is going.
In our unit, we are trying to avoid intralipid as such and give TPN unless we are not able to feed the patient for a long time. So that is, for the infection thing. But yeah, I think the current recommendation is unless you go to 2 to 3 and then check your triglycerides. Okay. I think we'll skip refeeding syndrome in these two. Okay, so what are the major risks of parenteral nutrition? Infection is one, sepsis is one, then electrolyte disturbance, no? So you can have hypernatremias, hyperkalemias, hypokalemia, all that, hypophosphatemia. PICC line related problems, PICC line can become thrombosed. Okay, extravasation can happen. Parenteral nutrition associated liver disease. That means cholestasis can be there once you give parenteral nutrition. That especially when you're giving lipids, you can have that. And then free radical damage. So what are the challenges in India? In India, I said we have to do everything in our unit. Nurses and doctors have to write. There's no pharmacist, dietitian. All these people who help abroad are not existing here. And then make sure you have laminar flows, infusion pumps to give parenteral nutrition, asepsis. So which infants benefit most from parenteral nutrition? How preterm? So less than 32 weeks and 1.5 kg. Some units might say 1.25, but these babies need parenteral nutrition. So if you are on any other indication for TPN other than preterms, surgical. So you're not able to feed them for a prolonged period. So that NEC, abdominal surgeries for atresias, all these patients can have, need TPN. So late preterm, moderately preterm, not so much. They don't really benefit for this. There is some idea that it can improve their brain growth, but not much evidence. So we don't usually give TPN to such big babies. When do you start doing enteral nutrition once you're on TPN? So as soon as the baby is ready, baby should be fed milk. That is some that you have learned from the first class. You have to start feeding even if you are on TPN. Even if the baby is very preterm, try to get some feeding at least. So as soon as you reach about 30 to 40 ml of feeding, you should per kg, you should try to start weaning your TPN. Okay. So usually by 120 ml per kg, if you are reaching feeding, you stop your TPN unless there is a problem with baby's growth and you want to continue for some more time. So that can be given along with enteral nutrition, but usually 120 you can stop your TPN. There are some trials which are showing the very early and high protein on day 1 itself. Compared to 2, you go up to 3.5 and 4 gram per kg. What happens to babies like that? Yeah, their growth sometimes is better, but some studies are showing that they can have head circumference being less. So these are still, people are wondering about how to start, when to start and all that. So there is some controversy about how much amino acid can be started on day 1, but right now we started 2 grams. Okay, so what are the gaps still that we don't know? What are the optimal intakes? What is the ratios that we use for VPIs? Critical illness. So some babies are sick. You're septic. What happens to babies' sugar when they are septic? They become hyperglycemic. So you might have to reduce your protein and glucose rates for those babies who are septic. Okay. Any other critically ill children also might need a less of both amino acids and sugars. Okay. Long-term outcomes, they have not been able to really show that because of TPN only babies are better, but definitely if you don't give TPN, there is growth failure. So we think that because it improves growth, it improves the brain function as well. And try to use the newer lipids like SMOF and all, because they have the omega-3 lipids in them. So that's about TPN in brief. Any questions, anybody? So I think the next talk will do the calculations of how to do TPN.